11:01.
Okay.
And I'll go live any minute now. You guys are live.
Shall I start now?
Yes.
So, very good morning to all of you. And here we are going to talk about this topic, nourishing the fragile. So, I am Himani Khantekar. I am the manager of the Human Milk Bank at Lokmanya Tilak Municipal Hospital. I'm also the lactation consultant over here, and it's been almost 7 years that I'm associated with this hospital. So, as we go ahead, let me just talk about breastfeeding, because we cannot go ahead with the milk banking before talking about breastfeeding. See, milk bank is not a substitute for breastfeeding. It's not a substitute for mother's own milk. It is only there to support sick babies who are there in the NICU, who are vulnerable till the time their mother's own milk is not available to them. If our breastfeeding awareness is not strong enough, it's not strong, then only establishing milk bank will not solve the issue. So we need to strengthen these practices. A strong breastfeeding support in every home, every hospital, in every community is the real foundation of the newborn health. So we'll just begin with our session now. So why do we feel breastfeeding is important? So breastfeeding is actually the cornerstone of child survival and development. Is it okay if I continue speaking English, or do I have to make a mix of Hindi and English? You just can let me know. Okay. So since ब्रेस्ट फीडिंग, क्योंकि हर बच्चे के एक जीवन की नींव है, शुरुआत अच्छी होनी चाहिए. एज वी से वेल बिगन इज हाफ डन. सो जो शुरुआत है वो माँ के दूध के साथ होगी, तो बच्चे का हेल्थ आगे किस तरह से उसका डेवलपमेंट होगा, दिमागी या शारीरिक, ठीक है, उस पर डिपेंड करता है. Suboptimal breastfeeding is linked to a substantial burden of diarrhea, pneumonia and undernutrition. अगर माँ का दूध सही मात्रा में सही समय पे बच्चे को ना मिल पाए तो इन बच्चों को बहुत सारी बीमारियां हो सकती है, जैसे कि उनमें से सबसे ज्यादा कॉमन है डायरिया, pneumonia, respiratory illnesses, then allergic conditions such as asthma, undernutrition. Baby may not gain weight adequately in required amount of time. National data shows that there are critical gaps falling short of global targets. तो क्या है वो हमारा national data और हमारे targets क्या है? So if we see that there are somewhere around 90% of the deliveries, close to 90% of the deliveries are happening in the hospital, institutional deliveries. But still, out of that lot, we are falling short in the sense, उनमें से सिर्फ 42% अर्ली इनिशिएशन ऑफ ब्रेस्ट फीडिंग हो पाता है, यानी कि शुरुआत के 1 घंटे से लेकर 6 घंटे तक में माँ के दूध पिलाने की शुरुआत होती है, और उस बच्चे को माँ का दूध 6 महीने तक मिलेगा, उसका परसेंटेज डेटा हमारे पास सिर्फ 64% है. सो विच इज वेरी शॉर्ट. आई मीन देयर इज अ बिग गैप एंड वी हैव अ लॉन्ग वे टू गो. तो सीधे सीधे फायदे क्या है माँ का दूध पिलाने के बच्चों और बेबीज को और माँ को, ठीक है. तो बच्चे से शुरुआत करते हैं. सो पहला फायदा, जैसे कि इट सपोर्ट्स बेबीज ग्रोथ एंड डेवलपमेंट एडिक्वेटली, ठीक है, सही तरह से उसका विकास होता है, सही तरीके से ग्रोथ कर्व पे आपका बेबी वेट गेन करता है. बूस्ट इम्यूनिटी, दिस इज वेरी इंपॉर्टेंट एक्चुअली, द फर्स्ट वन. जो रक्षा तत्व माँ के दूध में है, जैसे कि इम्यूनोग्लोबुलिन्स, सिक्रेटरी आईजीए, वो चाहे हम कुछ भी कहीं से भी प्रोवाइड करके दे दें, वो उसको रिप्लेस नहीं कर सकता, ठीक है. और जिसकी वजह से बच्चा वो कम बीमार होता है. There is a greater IQ. Definitely, it has been observed that the babies who receive mother's own milk, breastfeeding per se, they have a better IQ than the other counterparts who are given the other form of milk. Then it lowers the incidence of SIDS, which is sudden infant death syndrome. बेबी माँ के साथ रहता है, एक्सक्लूसिवली ब्रेस्टफीड बेबी पूरा टाइम दिन रात माँ के साथ रहेगा, सो एसआईडीएस का रिस्क भी कम हो जाता है. For mothers, it reduces the risk of cancers, for example, cervical and breast cancer. It aids mom's weight loss. It may take time because, see, firstly, जो यूटरस है वो उसको प्री प्रेगनेंसी स्टेज तक पहुंचने में मदद करता है. Then making when the mother is exclusively breastfeeding, so making up that milk again, it leads to somewhere around 500 calories per day consumption. So उसका weight loss होने में मदद मिलती है. The one very important which is not even mentioned here in this picture is it helps to create the bonding between mother and the baby, which is very important. And it eventually helps in lowering the incidence rate of postpartum depression and postpartum blues. So these are the breastfeeding benefits for mothers and babies both. Okay. What is colostrum? So when we talk about colostrum, अभी अगर ऐसा बोला जाए तो जो पहला पीला गाढ़ा दूध होता है उसको कोलेस्ट्रम बोलते हैं. महाराष्ट्र में हम इसे चीक का दूध भी बोलते हैं, ठीक है. हम तो लिक्विड दूध बोलते हैं. So this is very important. This is really the first gift of life to the baby from mom, because and it's small in amount but it has a bigger impact. Okay, it helps to build immunity, it supports digestion, it helps to clear the meconium, it is very rich in nutrient dense, and it's definitely helps with the great start. तो क्योंकि कोलेस्ट्रम जो है, जो चीकता दूध है, वो कम मात्रा में आता है. तो मदर्स को अक्सर या फिर घर वालों को भी अक्सर ये डाउट होता है कि सिर्फ कोलेस्ट्रम फीड करना इनफ है क्या, बेबी का पेट भर रहा है क्या. So let me show you an image. In this, it is clearly shown on day one, the baby has a this much sized stomach. The capacity is only this much, which is 5 to 7 ml पर फीड. अगर बेबी रिसीव करेगा तो उसका पेट भर जाएगा. और ये साइज कितना है, सिर्फ चेरी के साइज का, जो केक पे एक छोटी सी चेरी होती है. तो फर्स्ट 24 आवर्स में उसका साइज इतना रहने वाला है. ऑन डे टू it will progress and it will grow up to a size of a walnut. So day 2 पे उसकी जरूरत इतनी होती है. अराउंड आफ्टर 1 वीक एक एप्रिकॉट के साइज का हो जाता है बेबी का स्टमक साइज, और उसकी कैपेसिटी समवेयर अराउंड 45 to 60 ml है. और एक महीना खत्म होते होते एक बड़ा अंडा जितना होता है 80 to 150 ml तक का दूध अकोमोडेट कर पाता है. अब आप खुद ही सोचिए, जब ये डे वन पे चेरी के साइज का है, माँ का जो बेबी का स्टमक साइज उतना है, और ऐसे में हम जब ब्रेस्ट फीड नहीं करते और हमें ऐसा लगता है कि कोलेस्ट्रॉम काफी नहीं होगा, और हम बेबी को सप्लीमेंट करने की कोशिश करते हैं दूसरा कुछ देख के, तो एनीवेज वी आर ओवर फीडिंग द बेबी. इसीलिए वो वॉमिटिंग और दूसरी सबकी समस्या भी शुरू हो जाती है. So this is why we also recommend bedding in and demand feeding. Bedding in, rooming in means after the delivery, the baby and the mother are supposed to be together in same room, on the same cot, same bed. What will happen? How is it going to help? तो जब दोनों साथ में है, बेबी को वो स्किन टू स्किन कांटेक्ट माँ का फील होता रहता है. जब वो साथ में एक दूसरे को पकड़ते हैं, देखते हैं, माँ बार बार फीड कराती है, हंग्री बेबी है, वो स्टिमुलेट होता है कि उसको माँ का दूध सक करने के लिए ब्रेस्ट पे आना है. जब ये होता है तो वो अच्छे से खींच के दूध निकाल भी पाता है. द मोर इट helps to empty the mother's breast, the more of the stimulation is provided to the mom, and it will help in the best function. It helps to make it helps mothers to make those hormones which are required for milk production as well as milk excretion. So the more milk is released, the more it is emptied, and again, so this cycle goes on. But for how long she should feed? So we usually recommend one breast at a time. It should not be like when the mother has just started to feed and within 2 to 5 minutes she has her let down reflex. What happens in the let down reflex is when she's feeding from one side, the other side also starts leaking. So when that happens, most of the moms who do not have adequate knowledge, they have tendency to shift the baby onto the other breast. Now, when they do that, what happens? She will tend to give foremilk to the baby from both the sides. And now, what is foremilk and hindmilk? So, the foremilk is something which comes in the beginning of a feed when the breastfeeding session is started. इसमें बाकी सब सेम है, but it helps to quench the baby's thirst. It has more of lactose and protein, but it is not very caloric dense because it has less amount of fat. Whereas the other milk, which is hind milk, which comes, it has more amount of fat, but ये जब उसका breast feeding session चल रहा है, बेबी ने उसका माँ का breast almost empty कर दिया है, so towards the end of the session ही ये release होता है. So it's very important, it's imperative actually to feed the baby until the baby is able to drain that first. And if the baby is still hungry, then she can definitely switch over after some time. So we say that we have to look at the baby and not the clock when we are feeding the baby. Breastfeeding should be done only on demand, but it does not mean कि baby ने 4 hours तक demand नहीं किया क्योंकि वो सो रहा था, सुस्त था, demand ना करने की वजह से हम उसको दूध नहीं पिलाएंगे. ऐसे में पिलाना पड़ सकता है. ऐसे में आपको 2 to 3 hours से ऊपर का गैप होने नहीं देना है, तब बेबी को आप उठा के पिलाएंगे. Now, how does a mom know that the baby is getting enough of the milk? This is a very important thing because most of the mom have this question, this struggle. ये असमंजस हमेशा रहता है कि मेरा दूध पूरा भी पड़ रहा है क्या? Okay, so we need to know this so that we can counsel the mothers adequately. So when the babies are feeding, they will turn away. Once their stomach is full, they feel they get that satiety. After that, they will start turning away from the breast. They will leave the breast. They appear easily distracted as they grow up. Then they will slow down the sucking. You know, it happens during the beginning of a feeding session. Babies tend to suckle more frequently and not more frequently, vigorously, and but this will slow down over a period of time once they feel they are full. Then they begin to fall asleep. Also, their hands, body feel at ease and their hands are open. Usually in the beginning, they tend to make this kind of a fist when they suckle, okay? But once they are full, they are relaxed, their body feels at ease and they open their fist. The baby lets out a wet burp or hiccups. They leave the breast on their own. And another indicator is they have a good weight gain, which is half a kg per month is enough. When the mother comes for the follow up, she will know that there is how much of the weight gain how much of the weight gain has happened over a last month. So she'll come to know. Then there should be 6 to 8 wet diapers per day. This is the minimum amount. Baby can go on producing more. Okay, so what you see on the screen right now, what do you think? What do you think these things are? Should these be given to the baby, like water, sugar water, tea for that matter? I mean, you would say no, I know, but we have seen cases where we have seen, so, you know, some of the relatives offering 1 or 2 small spoons of this tea as well. Then honey, gripe water, and animal milk. So, yeah, the obvious answer is no, this should not be given. And in our hospital, when we talk, so we call them prelacteal feeds. So, prelacteal feed is something, it's any food which is except mother's milk, which is given to the baby before initiating breastfeeding. And there is one of the very common practice, honey. It should definitely not be given because it can lead to a risk of infant having botulism. Okay. Now I'll tell you, you may feel this कि हमने हमारे घर में या पड़ोस में या मेरे हॉस्पिटल प्रैक्टिसेस में कितने बच्चों को मैंने देखा है हनी लेते हुए बट उनको कभी भी इन्फेंट बॉटुलिज्म नहीं हुआ. So it's not that very common. Okay, this is one thing very important. It's not very common thing, but when it happens because of the spores of the Clostridium botulinum, वो जब होता है, it becomes very dangerous. It attacks the nervous system of the baby, and it can lead to paralysis. So it's a major dangerous infection that may happen. So this was a little bit about breastfeeding, because as I said, as I started my session with, that we need to spread more of awareness on breastfeeding before beginning to talk about the human milk banking. Only when we know the importance of mother's milk can then we truly understand the importance of our donated human milk. So now I hand over to Dr. Swati Manerkar. She is the in charge and head of the Department of Neonatology at Sion Hospital. Madam.
Hi, good morning, everyone. And it's a pleasure to be here with you. After understanding the importance of breast milk, we should we should realize that there would still be situations where mother's milk is not accessible to her baby, either because of mother's illness or because the mother is in a different hospital, the baby has been shifted to a different hospital. And basically, we have started this practice of human milk banking as a critical strategy to bridge the gap between exclusive breastfeeding till such time that the mother can make milk and make sufficient milk for her own baby. So, milk from the milk bank is provided to vulnerable and high risk newborns. To those who do not have immediate access to mother's own milk for various reasons, we must ensure that we are providing safe and pasteurized donor milk when mother's milk is unavailable or insufficient, which is a very important aspect. It has to be safe because we would be feeding one mother's milk to another mother's baby. It is also important that we provide human milk to support early feeding and therefore reduce the risk of life threatening infections like necrotizing enterocolitis and sepsis. And we must at all costs prioritize human milk over formula in neonatal care because human milk has a clear advantage over formula milk in saving newborn lives. And we would thereby want to scale up milk banking and integrate human milk banking within the breastfeeding promotion initiatives. And this program that we are having today is also a part of advocacy for improving availability of donor milk for those critical and vulnerable newborns. So, improve equity in access to human milk, optimize survival, and advance progress towards sustainable development goal targets set internationally. Briefly about the history of milk banking at Sion Hospital, it was established by a very senior neonatologist, Dr. Armida Fernandez, way back in 1989. So, out here at Sion Hospital, we have been running this service for more than 36 years. However, this practice is more than 100 years old. The first milk bank in the world was set up in Vienna, Austria in the 1900s, in the 1800s rather. And we could only start it here way back in 1989. And it has been doing a lot of work for the last 36 years, not just in banking human milk, but in promoting, protecting, and supporting breastfeeding. So, in the last 5 years, if I could talk about the recent past, we have had somewhere between 5 to 10,000 deliveries happening in the hospital, and close to 9,500 mothers have been donating their milk to the milk bank. We have collected close to 950 liters of milk every year, and this milk is fed to critically ill, vulnerable babies in the NICU who are preterm, who are low birth weight, and who are in need of human milk because they do not have access to their own mother's milk. So, what are the steps involved in milk banking? We start with screening and recruiting donor mothers. Once they are recruited or they're eligible as donors, we encourage them to express milk, collect it. Once the milk is collected, it is processed, tested for any contamination, and stored till it is dispensed to babies in the NICU. So, who can be potential donors for human milk. These are mothers of babies who are admitted in the NICU and who are not currently consuming too much milk. However, the mother is making a good amount of milk, which is in excess of the requirement for her baby. Mothers in the postnatal ward, especially when they get engorged in the early week, first week after delivery, lactating women amongst hospital staff, mothers of babies who are visiting follow-up clinics, vaccination OPDs for a regular baby checkup, and also any mother from the community who wants to donate her surplus milk, working mothers, these are all potential donors. So donor mothers can be categorized into two categories. Either they are cross-sectional donors or they are longitudinal donors. Cross-sectional donors are those who come to the facility, come to the hospital and donate milk. Longitudinal donors are those who collect milk at home and we arrange to pick it up from their homes. Certain prerequisites for selecting donor mothers. We must ensure that the mother is healthy. So we take a brief history of the mom, make sure there is no acute or chronic illness. The mother is not on medications or on any drugs. She has not been an organ or tissue transplant recipient for the last 12 months. She has not received any blood or blood product transfusions in the last 12 months. No high risk behavior like alcohol or tobacco consumption. And she has a normal breast examination, meaning there are no local infections in the breast. We also ensure that the mother is screened for three viral infections: HIV, hepatitis B, and a bacterial infection called syphilis by doing a VDRL test. In the West, more infections are screened for like hepatitis C, CMV, HTLV, but these are not compulsory in India. A woman can donate as long as she wishes to. So there is no upper limit to how long can a mother donate. As long as she is lactating and she's willing to donate, she can happily donate. It's just mandatory that we repeat her lab tests every 6 months to make sure that she still tests negative for all the transmissible infections and that she gives us a written informed consent that this is a voluntary donation before she starts donating. There are two ways of collecting milk. Either the mom can manually express into a clean container and donate it, or it can be done using electric breast pumps, which are personal use or hospital grade when we do it in the hospital, in the wards, and moms come and donate to us. Collected milk is subjected to pasteurization so that we destroy any bacterial contamination which may be present. It's done by a Holder method of pasteurization in a shaker water bath or a fully automated pasteurizer. We test these samples for bacterial contamination before a pasteurization and also after a pasteurization. A double check ensured to make sure that we are offering only the best quality milk to babies who are admitted to the NICU. Till we get a negative report, the milk is not issued to any baby in the NICU. Only once both reports are negative, we will safely dispense this milk. We have very strict criteria for which milk can pass the testing and which milk is to be discarded. So any gram positive growth of more than 10 raised to 4 colony forming units per ml or gram negative of more than 10 raised to 5 would be discarded. Or if there are air bubbles in improper seals to these bottles, those are discarded. And we can save this milk for up to 6 months at minus 20 degrees Celsius for use eventually. Who gets this milk and how do we decide which milk is to be dispensed to the babies? So it's always a principle of first in, first out. Donor milk is prescribed by the treating doctor. We are informed in the milk bank about the requirement in the NICU. The donor milk is transported to the NICU with a cold chain maintained. It is thawed in the NICU. And even before we feed it to the baby, the recipient's mother or legal guardian has to sign a consent that we are fully aware that we are getting pasteurized donor human milk, which has been donated by some other mother and it's not provided by the baby's own mother. Milk is fed using sterile feeding instruments by bringing it to room temperature. Which babies are prioritized? Premature babies, generally less than 32 weeks of gestation at birth. Low birth weight babies who weigh less than 1500 grams. Babies who are severely growth restricted, which means they have not met their growth potential in utero. And newborns who don't have access to mother's milk or the mother has a medical condition which makes it a contraindication for the baby to feed his own mother's milk. Babies with who are born to mothers with medical conditions and also satisfy the weight and gestational age criteria. Mothers who have lactation failure, multiple births, but all of this depends on the clinical judgment of the treating physician. And in every unit, there is a policy for who can be fed breast milk. It is not, it's a very scarce resource. So human milk, donor human milk cannot be fed to any and every baby who is not having access to his own mother's milk. It has to be prioritized for the smallest and sickest babies because it is life saving. So this is the whole process in a nutshell, where mothers are encouraged to become donors, and once we screen them, they donate milk. It is transported to the milk bank where it undergoes pasteurization and testing. It gets stored and then it is distributed to babies who are in need, preterm babies who are in need for human milk. And we must understand that we need human milk banks for the most vulnerable preterm and low birth weight babies because it saves lives, it supports growth and development of the brain. So, if we want to create a, a future generation of strong and able individuals, we must support the brain development of these babies, especially when mothers are sick themselves and are unable to produce enough milk, and to build a culture, very strong culture of caring and sharing. So, this milk will be provided only on the prescription of a doctor. It cannot be offered without prescription to any baby. Again, this is a diagrammatic representation of the same process, and we strongly appeal to all people in the community to help us find more donor mothers who will join us in our journey of saving newborn lives. So I'm open for any questions if there are any. If there are no questions, then thank you very much. Thanks, Manisha, for organizing this. And if there is anything, any other queries which need to be addressed, you could reach out to Manisha, who can forward those queries to. Thank you.